So let's do the journal club first, and then we'll do the test review, if that's acceptable for everyone. Again, I apologize for being a few minutes late, but you just have to deal with it. So I'm not going to sing for you. Just kidding. No. Okay, so let's talk about the article. Did anyone read the article or look at it?
Yes.
I hope so.
It was great.
It was a fantastic article, wasn't it? It's very straightforward, though, which is, yeah, so again, the idea is to start off straightforward, and then we kind of look to see how we're applying the different stuff we are covering in the material, and then see how that actually applies to a real deal case. And you guys notice when this was published?
Yeah, it was like the beginning of this month.
Yeah, beginning of this month, right? So this is like hot off the press, as they would say, right? Or hot off the PDF is what we got here. So this is like recent stuff, okay? So tell me, and again, you guys went through the questions that I think I posted along with it. Let me look here. I think, let me find the questions that I posted along with it. When you guys will, when I break up into groups for your future journal clubs, this is what you're actually going to be looking at as well. You'll be going through these going through the articles and then answering the questions. So this is basically what we're going to be covering. If there's anything I missed, just let me know and we'll talk more about it. So can anyone kind of briefly summarize what this study was looking at? Kristen, go for it.
Sure. So they wanted to see, they had it previously where people had already combined muscle relaxants with NSAIDs and it wasn't effective, so they wanted to see another combination of new muscle relaxant with NSAID would have an effect, and that was basically what they're trying to test.
Perfect. And so what kind of disease state were they looking at?
Acute back pain.
Yeah, acute back pain, right? So acute back pain presenting to the emergency department, looking to see like, okay, well, is just ibuprofen going to be effective, or how would it be more or less effective by combining it with a couple of different muscle relaxants, right? So that's essentially what they're trying to look at. And so again, you'll notice here, and remember we went through the bones of the article, right? So you can get most of the information right here from the abstract. Now, did everyone just read the abstract and then stop there?
Yes.
No, that's the wrong answer. You want to keep going. You want to get a little deeper into the actual article itself. So again, the introduction is going to go over kind of the basics, like what do we already know about the topic? Why are we interested in this? And is this a topic anyone should care about?
Probably, yes.
Why?
Because back pain's the most common complaint in the world.
It's a super common complaint. People are going to show up and you want to know how to treat it effectively, right? Or when people come in and they're like, oh, well, you know, I got really bad back pain. Can you just give me some opioids? And you're like, I'm not going to give you any opioids. I'm not going to give you OxyContin for this. However, I'm going to give you some ibuprofen. And what are they going to say? Hey, that's it? Just I could buy ibuprofen. Why'd I come to the ER just for that? I want something else. Can you give me some muscle relaxants with that? And you're going to be able to tell them whether that's a good idea or not, right? Off of articles like this. Make sense?
Yes.
This is why we care about this stuff. This is why we're interested in this kind of information. Now, if you read it and you were like, I don't actually care anything about back pain, I work in dermatology. Would you ever read this article? Chances are you wouldn't, right? But again, that's why I went off of the topics that most people were interested in, and emergency medicine happened to be the top one. I thought it was going to be super cool pharmacist, but that actually was quite low in the rankings, so there'll be no articles covered about that topic. But it is what it is. Anywho, so getting into it, so we have the goal of the investigation. So what's the main comparison we're going to be looking at?
Placebo group and experimental groups.
So we're going to have a placebo group, which is receiving what? Just ibuprofen. Good. And then what are they going to be compared to? So the different muscle relaxants, right? So the comparison is going to be between that, tizanidine, baclofen, and metaxalone. Now we haven't covered these drugs specifically yet. We'll get into them later on when we talk about like ortho stuff and talking about pain management. So don't stress about that too much. But as you might imagine, they're muscle relaxants. So what do you think they do? They relax the muscles, which makes sense because if you're having a muscle spasm in your back, that could be a source of the pain, right? Ibuprofen is obviously going to do what for that pain? Decrease inflammation. Very good, right? So it's an anti-inflammatory plus this muscle relaxant. We're looking to see, is there synergism there, or is it reasonable just to use one drug by itself, right? Because what's the risk of using more drugs? More side effects. Anyone know what a common side effect is of a muscle relaxant?
Yeah, you're like
Sleepiness, right?
Yeah.
Drowsiness, dizziness. You can see a lot of these are typically sedating medications. They don't just work in the muscles to relax them; they actually work up in the CNS, and so you see a lot of sedation associated with these as well. So again, if I can avoid giving an extra medication due to increased side effects, and that if it's just as effective, then just use the anti-inflammatory by itself. Very good. So those are going to be the comparisons here. Now notice it says this is a randomized trial, which means what? So as they come in and they're getting incorporated into the study, right? So what do they have to do first in order to be included in the study? Yeah, you should have back pain first. So again, if they're coming in for the sniffles, then obviously you would not want to include them in the study. But what else do they need to give? The patient has to give you before you can enroll them. Consent, right? So we'll talk about consent a little bit later and going through the IRB process and whatnot. But once they get enrolled into the study, then they get randomized, right? So which group do they get put in? It should be random, right? And who was doing the randomization? Anyone read that? It was the pharmacist. Why was it the pharmacist? Oh, double blind here, right? So what does double blinding mean? So the people giving the medications will not know, like the actual prescribers will not know. And who else doesn't know? The patient, right? Why does the pharmacist have to know? We got to know what drugs to give the people, right? So again, that frequently comes up as where if we're preparing the medications for trials like these, the pharmacist will know what group the patient's in. However, the providers and the patients will not, okay? And again, what is the purpose of having placebo control here? To control for placebo effect, right? What is placebo effect? Mind over matter, right? So you taking something for your back pain, you assume it's getting better, you feel like it's getting better. Guess what? That's placebo effect. So that's why we use that as our control group. Now, how come we gave the patient, and again, how do they control? How do they actually do the blinding? What was the process there? So they gave him 2 pill bottles. One was labeled ibuprofen, right? Because everyone got ibuprofen, so that was not so much of an issue. What did the other patients receive? What was the second bottle? It said investigational medicine. How do they? Because I mean, a tizanidine looks different than a metaxalone, looks different than a baclofen. How do they control for that? They put it into so an anonymous capsule. So all the capsules looked identical. So even if you're the prescriber, you'd be able to look at it and you have no idea, right? Now maybe you could shake it up. How do they actually deal with that? They put like lactulose in there, I think, as well to make sure that way they couldn't it's not like you're checking for Christmas presents or something. You can't tell if you're getting like a bike or something, but really big Christmas present. Anywho, so that's how they control for that, right? So again, it's important they talk about the blinding procedures because if you just got a pill and you looked it up, you could tell exactly what it was. You didn't know already what you're getting. So that's an important process here. So anyway, so that's how they end up blinding the study there. Okay, so it's a randomized placebo-controlled trial. Right, and so we have 4 different arms as we mentioned. So all of a sudden you see 4 different arms. What are you starting to think about in terms of statistical testing? Multiple groups, right? Multiple comparisons, right? So this is where also you want to kind of key in and look at, okay, well, what actual comparisons were they doing? Did they control for this? And that's going to be another question we're going to be looking at just a little bit. So already some of the things we've kind of gone through in the lectures are kind of coming up here. How do they select participants? So we mentioned they have to present with back pain. What were some of the inclusion and exclusion criteria? Age, right? So we were looking at 18 to 64-year-olds patients. So can I draw any inferences about 17-year-olds from this study? Not technically. Is a 17-year-old probably going to act similar to an 18-year-old? Probably. Can I say anything about 2-year-olds? Probably not, right? They're pretty dissimilar. What about like an 80-year-old?
Not necessarily.
Not necessarily, right? You're able to draw less and less conclusions as soon as you get outside of that age range, right? But it's important they specify who they're actually looking at. But again, when you get into older patients, what are you also worried about giving all these medications to? Drug interactions, comorbidities, all these different things, right? So those are things to consider. It makes it a little bit simpler if you're looking for this. It's still a generous age range, but not as broad as it could be, right? So presenting for back pain, what else do they? Would be things that would keep them from getting enrolled in the study? Yeah, other medications maybe they're taking, maybe chronic pain medications, right? What else? If they're pregnant, why don't you want to do pregnant patients? They have back pain. Have you ever been pregnant? I haven't by here. Their backs hurt. Yeah, you don't want to give unnecessary drug exposure to pregnant patients. It's a big ethical no-no, and so frequently you wouldn't be able to get that through the IRBs, right? Well, why do you have to give this to pregnant patients, right? So that's one of those cases where that would be, that's why that's a common exclusion criteria, right? What else? The allergies would be good, so if they have allergies to any of the medications. What else? Yeah, so they already have chronic pain. This is supposed to be for acute presenting pain. Or if they have recurrent episodes, what was the time frame from the last one?
2 weeks.
Yeah, it was like a month or something, or 2 weeks?
It was like more than 2
Yeah, something like that. So there was specific criteria there. So they wanted to make sure it was not someone who had a continuous chronic issue. Remember during the CHF PD lab, we talked about acute on chronic issues, right? So you don't want this to be like an acute exacerbation of a chronic problem. This just should be like kind of a perhaps maybe a recurrent sort of acute issue, right? It's not a chronic problem we're dealing with. Okay, good. So then what else did they look at? Also, these charts are really helpful to kind of evaluate these sorts of things here. So looking at this, any other things? Direct trauma, right? Those are something they're counting out. Pregnant patients I mentioned. No, not functionally impairing. What does that mean? Like my back kind of hurts, but I can still do all my activities of daily living, right? That's just being like over 30, right? This stuff hurts now. That doesn't really impair my function much. All right, so those are the things we're going to be focusing on here, right? So those are going to be the exclusion criteria, and then the inclusion would just be patients presenting in the age range for that acute back pain, right? Good. So how did they determine how many patients they wanted to enroll in the trial? Because you see, they actually excluded quite a few people, about 1,000 people, right?
Yeah, look at like the relevance of like past trials and how many drugs they need, like how many people would be significant.
What do you call that when you're trying to figure out how many people you want to enroll? So we're looking for the number of people we need to really find a difference there, right? What do you call that? The ability to detect a difference should one exist. The power, right? Tim, the tool man Taylor, he wants more power. And so you got to do power calculations to do that, right? That's what a power calculation is. You look at previous studies, you look to see what kind of effect size you're looking for, you're looking to see what kind of variation you should expect in the data, and then you can expect how many patients you would need to really find a difference there. And so if you go through, what do they do, the power calculations? Right here, if you look at this section here, they're looking at, based on normal standard deviations. In an earlier study, they went with an alpha of 0.05. What does that mean? That's their significance level. So they have to have p-values that would be less than 0.05 in order to achieve significance. Is that reasonable? Yeah, that's the standard. Absolutely good. And this beta of 0.2, that's pretty typical for power calculations, right? So that's the power you need in order to show that difference. That is just a standard one, even though we didn't really delve too deep into that. But they said using their criteria, they needed 50 subjects in each arm. Did they achieve that?
Yes.
Did they exceed that?
Yes.
Yes, good. What if they got under that? What would you be worried about? What kind of errors would you be worried about? Type 2 errors, right?
Oh, yeah.
So if you're underpowered, then you may not be able to detect that difference, even if one exists. I just don't have enough people to actually show that. So that would be an example of an underpowered study. But how many people did they actually enroll in each group? Right, if you look back here, and I'm sorry if I'm like causing any nausea by flipping through here, but apologies. Anyway, so they enrolled 80 into each arm, right? And they talked about the randomization procedure that was carried out by the pharmacist, right? And then you see here, what happened to these numbers here? Why are these lower than 80? People fail to follow up. People maybe, if I get if you had a random phone number come up on your phone, do you answer it? Heck no. No. People leave a voicemail. Who does that in 2019? No, forget that. So it could be that people were lost to follow up because they maybe didn't answer their phones, things like that. And say, just text me. Text me the scale. I'll let you know how my back's feeling, right? So that's going to be the thing there. And we'll talk about intention to treat analyses and sensitivities and things like that a little bit later on. So, okay, so now we know who we got into the study. We know how they're getting randomized, how they're actually carrying out the blinding procedures, and all of that. So what are they specifically measuring on these patients? So is it just pain scale? No, they're looking at disability, right? This is a big shift in pain management we're looking at now. I don't care what your pain scale is on a scale of 1 to 10 necessarily, because that number is objective or subjective. Extremely subjective. Someone's 4 may differ greatly from someone else's 4 out of 10 on a pain scale. However, what is something more objective? The actual disability. Is your pain preventing you from doing something? That's something that's functional, and I can objectively measure that. And so, did anyone actually look at the scale? No, well, I have one here just so you can look at it. Because this is good. Because again, if they use a scale, one of the things you always want to see, because again, patients are answering these. So what are some concerns with that in terms of answering these kind of? They could lie, right? Why would they lie? To get more medicine? Maybe instead of saying, "Man, I'm really high on the scale here. I'm at 23," right? Did ever talk about the comedian who had to go to the ER and he was trying to figure out the right number to answer to get morphine? He settled on 8 was like just the right answer. So he's going to the ER going, 8, give him an 8, you're going to get morphine, it's great. 8 is great. No, so these are things too where they may be falsifying the information, right? But presumably people are going to answer this honestly, right? People are honest by nature, right? Up for debate. Anywho, what are some other things to consider though? Yeah, maybe they couldn't comprehend it. If you just hand them a piece of paper and they're like, I'm just going to mark off everything, that could be something to consider. What if they don't read English? All right, what other things?
Some of the things on here are subjective.
Yeah, so it could be a little bit subjective, right? So would you consider this, and they based it off their score, right? So what was the maximum score they can get on here?
24.
24, and that was most debilitating or least debilitating? Most debilitating, so higher numbers are going to be worse here. And again, do you think every person, you say a 16 for person A is the same as a 16 for person B? Not necessarily. How do they treat these numbers here? What kind of variable do they, what kind of level of measurement? Do they consider this like an ordinal scale, a continuous scale? What do they treat it as?
Ordinal.
It looks like an ordinal to me. However, when you actually look at the analyses, they're doing it as like a continuous scale, right? So that is one thing to make note of there, is just that, okay, even though it does look like an ordinal scale, because again, if you have an 8 on this scale, it could be very different than someone else's 8, I think, based on the functionality impairment. Again, they're all weighted exactly the same, right? Every one of these disabilities is weighted the same. They're treating it as a continuous. So just kind of one thing to note in terms of like trying to evaluate different levels of measurement, because that is something you'll have to do on the test, right? You have to know if it's nominal, ordinal, continuous, interval ratio, things like that, right? You guys will hopefully watch that video so you know what I'm talking about, right? See, not a lot of lights going off in the room, so just kidding. You guys will be great. Yes, ma'am.
It says, for methods, it says we use an ordinal pain scale.
Yeah.
Okay, so what's an ordinal pain scale mean? How do they actually categorize that?
Always, usually.
What do they have? What page is that on?
I think it's fine.
Methods of measurement here. Yeah, so when they do that, how do they categorize them? Severe, moderate, mild, or none. Does that make sense for it to be an ordinal scale? Right. However, if you had to say they did it at 1 to 10, again, that would be something as well that someone's 4 could be very different than someone else's 4 because it is somewhat subjective. You still treat that as a continuous variable. They did a 1 to 10 scale. So just something to kind of note. You may see that in other studies coming up. Okay, so they're measuring on this functionality scale. So good to know. What other things were they looking at? What are their outcome variables? So looking at pain scale as rated by that ordinal scale. What else? If they saw other healthcare providers, remember these are other things they're looking at. What else? They went back to work, so again, functionally, what could they do afterwards? When did they follow up with these patients?
2 days and 1 week.
Yeah, 48 hours and then 1 week later, okay? Do you think the results might change if you looked maybe 2 weeks out? Yeah, how about a month out? Yeah, right, so again, these are things to consider, right? So again, but patients may be coming back to the ER in 2 weeks, so maybe that is a reasonable time frame to be talking to ask them again, right? Or 1 week, whatever the case may be. So anyway, so these are the things they're looking at. In this case here, what is the independent variable in the study?
Yeah.
Which med group they get put into, right? Which they get placebo or if they get one of the muscle relaxants, okay? What is the dependent variables? The disability scales, the other outcomes we're looking at, as we mentioned. Do they go to see another healthcare provider? Why are those considered dependent variables? They're dependent on what group they got put in, right? What kind of medicine they were receiving there, okay? Very good. And so they did their analysis, and then what are the kinds of things that they're looking at? So they talked about confidence intervals, and they're going to be expressing those. We'll look at to see if they achieve significance anywhere or not. And they talk about their power calculation. And so it's always good if you can evaluate that because you want to see if people met their power calculations. In this case here, they did, right? They exceeded that, which is good. So if there is a difference between the groups, should they be able to find it? Presumably, yes, they should. Okay, but we'll see how the results actually bear out. So again, they enrolled the patients, they covered them over a 15-month period or so, and then let's look at the actual outcomes here. So let's look at baseline characteristics. So this is always important to look at because by randomizing the groups, what do you expect to be the makeup of the groups? Should they be similar or very different than one another?
Similar.
They should be similar, right? So you should have a similar proportion of gender, you should have a similar age group, you should have similar characteristics because if it's truly randomized, then the outliers tend to balance each other out, okay? So what do you notice about the mean age?
It's about the same.
Looks pretty similar, around 40 years old, late 30s, 40s, right? How about the proportion of men to women?
Roughly similar.
Well, maybe the ibuprofen plus baclofin's a little off from the other ones, right? Now, how could you test to see if these are truly outliers or not? You could do things like outlier tests, right? So again, these are things that maybe the researchers did not do, but we'll see if that's going to be a problem or not. But anyway, so the main thing is to look at to see, do these groups kind of look similar to one another? Now, frequently you'll find in some bigger studies, they'll actually be able to control for some of these things. So they'll control for age, they'll control for gender, they'll control for these sorts of things. But this is a little bit simpler of a study, which is good for our purposes since we're just starting out with these things, okay? So anyway, and then they're looking at the actual scores when they're starting out. So the actual scores on the scale here at the ED visit, and again, those should also be pretty similar to one another. Should be presenting with a similar level of disability, right? If they got randomized appropriately. So let's look at the results. What did they actually find? So again, and they wanted to know what was the mean improvement. Okay, so we wanted to see how do they improve from their baseline to the follow-up. Okay, this is the 1 week outcomes, and that was kind of their primary outcome they were looking at. So what do you notice about the different groups here?
They overlap.
Just their mean improvements. You notice that they look wildly different?
No.
They're very similar to one another, right? We notice about the confidence intervals.
They overlap.
So there's some overlap, but we can't really tell significance just from that, right? So we're just looking at the pure numbers by themselves, right? We're just describing the different groups here. Are they pretty wide, pretty narrow? They're fairly narrow, right? So there's probably similar amounts of variation in the data. The standard deviations are probably similar between each of these groups here. You don't notice that one doesn't go from like 1 all the way up to the 23 or something like that, right? That would be a very wide confidence interval in those cases here. But these tend to be pretty tight, so that's seems to be somewhat reasonable. And then you notice here, I guess some people that are missing out of here, that's going to be those people that failed to follow up, things like that. So that'll be important when we talk about the analysis in a few minutes here. Also talk about their median scores with the interquartile ranges, right? What is an interquartile range? Yeah, usually the 25th and the 75th percentile, right? So that's sometimes is expressed on this data here. And then, so looking at this, you notice these little symbols. What do these mean? You got to look at the footnotes. This is what we actually care about. This is they buried the lead a little bit in this graph here or this chart because this is actually what I'm really interested in. So they're looking at the absolute differences between the groups now. Okay, so now they're comparing placebo to each of the individual groups. Now notice, are they comparing any of the muscle relaxants together? They did not do that, right? So again, they're limiting the comparisons they're really making here by just doing placebo versus baclofen, placebo versus tizanidine, placebo versus metaxalone, okay? Now what do they notice here? Because there are differences between the groups. So for instance here, the 0.5 difference between ibuprofen and placebo and then ibuprofen and baclofen was negative 2.4 to 3.4. So what does that mean?
Not significant.
So why do I care if it includes 0? I'm looking at a difference. It's an absolute difference between the two groups. I'm looking at one minus the other. So if that includes 0, because if they're the same, it should be what? There should be 0. If the two groups are exactly the same, it should be a difference of 0. So if the confidence interval includes 0, that means that it is not statistically significant. So in this case right here, I can say that the baclofen group did not do any better, or any difference there is just due to chance alone, most likely, versus ibuprofen and placebo. Now, do I need a p-value here to know that? No, see, oftentimes you don't even need the p-value to show you anything. Okay, if you can understand and interpret the confidence intervals, that's all you need. Okay, what about with the 1 point difference between ibuprofen, placebo, and the metaxalone group? Not significant. Okay, what do you notice here about this group here, the last group?
They're very close.
Pretty close, but again, no difference, no statistically significant differences between the two there. Okay, now again, what if this was significant and the patient had a 0.1 mean difference between the treatment and the placebo group? Would I consider that clinically significant? Probably not. Would I consider 1 point significant? It's closer, right? If I saw like a 5 point difference,
Yeah, that's what
that's probably pretty good, right? The disabilities are going to be much less than that person. They're getting 5 points on average less than the other group. So ultimately, we can find that there seems to be no statistically significant difference between these two. Now, we mentioned there's multiple comparisons going on here, and if you read through it, you'll notice there's no mention of things like Bonferroni corrections and things like that. Does it matter in this case? Why not? Because multiple comparisons lead you to make what? Type 1 error. Type 1 error is when I'm rejecting the null hypothesis when there's no difference between the groups. Have I rejected any null hypotheses here?
No.
No, because what's my null hypothesis? All the groups are going to work exactly the same, and that's exactly what we see here. Now, have they made a type 2 error? Potentially. It's unlikely, though, because what? They met their numbers, all right? They met their sample size they were looking for, okay? Now, also, what are some of the problems, or what are some reasons why they may have found no difference here? What are some of the limitations I talked about? Yeah, maybe the dose wasn't right. Maybe they given different doses. How do they dose the muscle relaxants for those patients?
Take 1 to 2 tablets.
Yes, they take 1 to 2 every 8 hours. So what if you had a bunch of patients only taking 1, and then in another group had everyone taking 2? that could be a limitation, right? So because there could be differences in actually how the patients are being dosed, that is something you want to keep in mind. So that's one thing that I would critique the article for, saying, well, we don't really know a good number of like what actual milligram amount they were receiving on average, and so because of that, we can't say maybe they're underdosing or overdosing themselves. Okay, one thing to note. What was another outcome they looked at in terms of, what about like how do they report adverse effects?
They had a table of it.
Yeah, they called them and they say, hey, did you have an adverse effect?
Yeah.
And they said yes or no.
Yes.
Okay, well, how do you?
None were serious, right?
Yeah, how do you know? So let me find it here. Where was that?
The table's like the last table.
It's like the last table. Yeah.
Yeah.
Yeah. So did you have any adverse effects? Yes, no, missing, right? And I like reading the ones that they expressed here. So for instance, some of them you're just like, well, that has nothing to do with the drugs, and some of them make total sense, right? So for instance, in just the placebo group, they had drowsiness. Did you expect to see drowsiness with placebo in ibuprofen?
Mm-mm.
Does ibuprofen cause you to be sleepy? Not typically, but someone got a little sleepy and they said, yeah, I had an adverse effect. Okay. So again, just because it happened doesn't mean it's that directly related to the medications as well. So like someone had vaginal bleeding. Could that happen with ibuprofen and a muscle relaxant? Maybe with the ibuprofen, but because someone just started their period, maybe? Possibly. I have no idea, right? They don't delve any further. So I really can't say anything too definitively about the adverse effects people were experiencing during the study. I can just say whether they had them or not, whether the differences were significant. So ultimately, what do you think is the takeaway from this article? I'm not going to delve over every single outcome, but what do you think is the takeaways from this?
Don't add a muscle relaxant for acute back pain.
As far as we know, there's no additional benefit of adding a muscle relaxant on top of ibuprofen, right? And so now when your patient's like, no, I want a muscle relaxant to go with that, you can say, actually, it doesn't do you any additional benefit. And they'll say, yeah, but I still kind of want it. And it's like, I'm not going to do it for you. And then it's kind of awkward silence, and then you just walk out of the room, okay? You make the drop the mic motion and then walk out, okay? But no, so that's essentially what they're saying is that, again, less drugs may be better in some cases here, right? Any questions about that and kind of going through and evaluate? Oh, one thing I do want to know. So the scale that they used, what if they changed the scale? What if they had done something different, a different type of scale? Could they made a difference on the results? 100%. You always want to make sure whenever you're using a scale that it's validated, okay? And how would you know if it's validated? They'll talk about it, right? So let me find it here. There's a measurement. Right, so it said to measure low back pain, and notice here that how you can actually get to it. They mentioned somewhere where it's like it's used in other research. So if it's something that's used a lot in other studies, they call that being validated, right? It's a validated measurement tool, okay? Because you don't want to use something you just made up yourself because you have no idea how it would perform if someone else did a similar study, right? It could be wildly different results. And so how would you find where they pulled that information from? The bibliography, right? So always check out your bibliography, make sure that kind of makes sense. The articles that they're pulling here, you can always use this to go do further delving into the research too. I thought one of the charts they had was kind of interesting. You don't see too many that are like this.
Yeah,
so this took me a few minutes to kind of make heads and tails of it. I was just like, well, it looks pretty, but like, what does it even tell me? So what does the top of most of these lines indicate?
Where they started?
Yeah, this is their baseline score when they presented in the emergency department, and then what is the bottom of the line here? That's the change, right? The change in disability scores. And so are some of these actually going up? Yeah, some had more disabilities after the intervention than they did beforehand, right? So again, you're going to see some of that natural variability here. Now, does it make sense based off of the drugs we gave them? No, but other things could have been going on, right? What do you call that when you have outside influences affecting your results? Confounding variables, right? And so you have to address that. Hey, do we account for confounders and affecting these results here? Okay. Any questions on that in terms of interpreting a study? This one's pretty straightforward, which I thought was a good, easy one to start with. We'll get a little bit more complicated as time goes on. Basically, it's going to be kind of luck of the draw, whatever I find when I do some cursory PubMed searches. Anything at all? You guys ready for a review? You want to take like a 5-minute break and come back and do a review?
Sure.
Let's do that. 5 minutes and come on back. All right, let's do a review. These questions should be somewhat similar to what the test is going to look like. So if you can get a good handle on these, you should be all right. Now, the answers are down in the actual notation section there, so don't look ahead. That's for your review, okay? So don't look ahead because I want to see how you guys are doing now. Did you already look? Oh, no. Huh? I mean, you can look at the power. You can just minimize the note section maybe. Or just whatever you got to do, right? So anyway, you guys will figure it out. You guys are all very smart. Anywho, so let's start off with question 1. This is a definitional sort of question here. Let's say, what is meant by the standard error of the mean? Is it an estimate of the standard deviation of a group of sample means around a population mean? Is it a measure of the frequency of an occurrence over some time interval? Is it a relationship between specificity and sensitivity? Is it a mathematical equation to convert non-symmetrical data into normal distributions? That's some of the stuff we haven't even talked about. Think A?
Yeah.
That is true. It is A. If I say something wrong, you guys can look at the notes and back me up, but I should be right most of the time. Anywho, 95% of the time, I'll say that I'm right. How about that? That's actually way lower than that. Anywho, yeah, so the standard error of the mean is basically saying, like, how close is the mean you have in your sample compared to the mean of the actual population itself. Now, how does this compare to standard deviation? Standard deviation is the variability around the mean of your sample, right? So if you have a very wide amount of variability, so for instance, if I was drawing out something with a lot of variability, you would see it have a pretty wide kind of curve to it, right? So if my mean's there, now it's usually be a much straighter line, but let's say my mean is right there, you see it's very wide versus something with low standard deviation would look much more narrow, kind of like that, right? Looks like the top of Patrick or something, but you see that typically less standard deviation, smaller standard deviation means less variability around that mean, okay? So it's kind of the difference between those two there, okay? Makes sense? Yes, ma'am.
So in your PowerPoint, it says if we have a larger standard deviation, the sample mean is likely to be further from population mean.
Yeah, so there's a possibility that your mean could be different than the actual population mean. That's why I use the standard error of the mean. So that will incorporate your standard deviation. And so based off of that standard deviation being smaller, then you get a smaller standard error of the mean. Don't get too lost in the math of it. Just know that when you have a smaller standard deviation, that it usually means that you're going to have more confidence that your mean is very close to the population mean. Okay. But again, definitions will be something that will be a couple of the questions that are on there. So that's something that's good to know. Anywho, let's say we have a clinically accepted value for mean fasting glucose in females aged 20 to 29, and that value is 100 milligrams per deciliter. Okay, we know the standard deviation is 10 milligrams per deciliter, and now we have a fasting glucose for a 25-year-old female who comes in, and it's 130 milligrams per deciliter. How many standard deviations above the mean is that subject's blood glucose? Why 3?
Because it's 10.
100 plus 10 plus 10 plus 10, right? Very straightforward. So you'd say there's 3 standard deviations above. Now, is that a very likely value to get in a patient like that, or is it unlikely? Right, because again, as you get further and further away, you're going to get fewer and fewer people that actually meet, or actually you're going to have a value like that. So again, if you look at your normal standard distribution curve, right, so say your mean's right here, how many people are going to be in between the first standard deviation?
8%.
Roughly 68% of people should fall within that. So most of your individuals will be somewhere between what values? 90 to 110, right? Because we're going to 1 standard deviation either way. If I go out to 2 standard deviations, I should get how many people?
95%, 80 to 120.
95 of the people should be within 2 standard deviations of that mean, okay? Which means it'll be somewhere between what? 80 and 120. And then finally 3 standard deviations out, how many people? Yeah, 99% of everyone should be within that range there of 70 to 130, right? So if she comes up anything above that, then she is definitely in this very small number of individuals, so like the 0.5% or something like that, okay? Make sense? So again, it just tells you how far away from the normal mean for someone of that particular definition she falls away from the average, okay? So let's say we're looking at statistical analysis, we're looking at alpha or type 1 errors. Which of the following is going to be true here, right? So does this mean it's the probability of rejecting the null hypothesis when it is true? Is it the probability of failing to reject the null hypothesis when it's false? Is it the probability of keeping both the null and the alternative hypothesis when neither is true? Or is it the probability of rejecting both when both are true? The last two don't even make sense. You can't keep both of your hypotheses. You got to have one or the other, right? So the question is, which one of the first 2 answers here? So a type 1 error is saying what? It's saying I reject that null hypothesis. I said there is a difference in the comparison I'm making, but one does not exist, right? The type 1 error. So just like in the study we were looking at, they kept running different comparisons. They kept comparing baclofen to tizanidine and metaxalone to baclofen. Eventually, you might have found an error, right? You might have found an actual result that would have been a type 1 error, okay? What is a type 2 error? I keep the null hypothesis, even though there is a difference between the groups, okay? So again, it's a type 2 error. Again, as I mentioned, it's usually due to underpowering of the study, so not having enough people participating is usually where you end up finding that being a big limitation for most studies you're going to run into. Okay, make sense? And again, my null hypothesis is always what? No difference between the groups, right? Whatever intervention I'm introducing, surgery or not surgery, drug or no drug, there's no difference between the groups. Okay, let's say I have a clinically accepted value of mean systolic blood pressure for males aged 20 to 24 is 120 millimeters of mercury, and the standard deviation is 20 millimeters of mercury. What proportion of readings should I get if I sampled males 20 to 24 years of age? Should range between 80 to 160. Why 95? Exactly, that's 2 standard deviations either way. Again, drawing that out, my mean here is 120 millimeters of mercury systolic blood pressure. Again, going out 1 standard deviation is going to be 68% of people. 95% of people should fall within 2 standard deviations, right? So there's 95 in this group here. They should fall somewhere between 80 to 160, okay? Because again, if I got a value of 170, would that be pretty odd? Yes. Now it's pretty wide standard deviation. It's probably not true. I doubt many males 20 to 24 have values that are getting somewhere in the 160s unless they got some other issues going on. But again, this is just for the sake of example here, right? So again, you should be able to interpret standard deviations and means and all that kind of good stuff. Okay. Using the empirical rule, we've already kind of talked about this. How many percentages, or what percentage of observations will lie within 3? 99%. Okay, so again, you probably get a few questions about interpreting those. That's probably why I've harped on it by a couple points here, okay? So let's say we set our significance alpha level to 0.05 and I get a p-value of 0.1 as a result of my experiment. What does that indicate? Does it indicate the results of a study are statistically significant? Tell me the results of a study are not statistically significant. Or am I unable to determine whether they're statistically significant, or the results of the study are more reliable than expected? B, the results of the study are not statistically significant. Why? Because it is greater than 0.05, right? 0.1 means what? That the results that I found are, you'd find that 10% of the time you find results at least that extreme, or say more so, right? So it's saying that it's just too likely that this is due to chance alone that I cannot reject the null hypothesis, okay? Now what if I got a p-value that was like 0.051? Look at the context. Absolutely. If it's a lot of times you'll see in studies they'll say it's trending towards significance. That's researchers trying to like just grasp for something. They're like, I know this doesn't show anything, but it's trending towards significance. It's please don't say I wasted my time. Like, so those are things you're going to see there too. So if you see trending towards significance, I mean it did not reach the criteria. It's not less than 0.05, but it's getting close. Okay. So could a result be not statistically significant but still clinically significant? Again, context matters there, right? So if the value came up on as 0.2. That's probably not going to be very close, but if it was 0.055, maybe you'd want to take another gander at it, right? Because then frequently, if they get like to 0.055, what's likely the issue there? Could be a type 2 error, and it could be a sample size issue, right? So maybe if they'd run the study again, same conditions, but they include more people, then maybe that would have trended down maybe to say 0.04. Make sense?
Yes.
So you're going to be able to interpret those p-values. Yes, ma'am?
Could you repeat what you said about the 10% of the time?
Mm-hmm. Yeah, so in this case here, by running my study, the results that I found, I would have, if I kept running the study over and over again, ad infinitum, I would find that same exact kind of result at least 10% of the time. At least that extreme or more so, right? So it's just saying that it's too likely to be due to chance alone that I cannot reject my null hypothesis. Okay? Okay. The width of a confidence interval is influenced by which of the following? The standard error of the mean, the p-value, the sample size, or the F ratio? I didn't really cover F ratio, so don't worry about that. What's it going to be a factor of? Sample sizes, right? More of a sample size, what does that do for me? Increasing the number of people, I'm increasing the percentage of people out of that whole population, because ideally, who would I like to sample? Everyone in the population I'm curious about, but I can't do that. It's not logistically reasonable, and so I get a sample of that. So the bigger the sample size, what does that do to my standard deviation? Shrink it potentially. You may still find some variabilities just naturally there, but hopefully I'll shrink it down. But the confidence interval specifically will definitely shrink down, because then I'm more sure, or I can say that there's a small number of values that I'm 95% sure are going to be representative of that population. Yes, sir?
The answer is C, because it influenced, right? They're created by.
Exactly. So some of the other things are going to be factors of, right? So for instance, you can standard error, the mean is a result of things like sample size and also things like your standard deviation that can influence your confidence interval, certainly. But the one that we can have the biggest influence over, or things that we should be looking at in these articles, is going to be sample size. Okay, they can't change anything about the variation of the data, but they can try to get more people in the study. Okay. Very good. Let's say we're reviewing a survival analysis study in a medical journal, and you note that the study has an N of 200, so it means how many people are in the study? 200, very good. All enrollment happened in year 1, and the study ran for 10 years. So at year 2, there's 177 people that remained in the study. At year 2.9, 165 remain. At year 5.8, 100 subjects remain. And then at year 10, 75 people remain. What's the median survival time here? Can we determine it?
Yes.
Median survival time. How many people need to be in the study to get the median survival time? Half, right? Because it's my middle value there. So it means that whenever I had 100 people still left in the study, that's my median survival time, okay? So by the time 100 of those other people had whatever outcome, whether it be death or cure or whatever the case may be, that yes or no sort of phenomenon that can only happen one time, that's when they get out of the study, okay? So the median survival time in this case would be 5.8 years. Now, could I determine what the mean survival time was?
You could, but it'd take a lot longer.
Well, not at 10 years, right? So because I still have 75 people left over, I don't know what my total numerator is going to be there, or so because that you can't really get a good mean value. That's why we use medians, okay? I think it's 10 years is a long time to run a study.
Probably.
I mean, like 10 years is like half of your lives for some of you. So I mean, probably. So think about it. I mean, like these studies can go on for long periods of time, but it gets much more logistically difficult the longer the studies goes on for. Yes, ma'am.
So if that says the mean survival time, that would be a totally random.
You couldn't determine it. Yeah, that'd be D in that case there. I would not do something like that to you on the test. This is for illustrative purposes here, right? I'm not going to be that mean. There will be answers for all the questions. You may not think so, but there's answers there.
So the mean one is when everybody.
Yeah, so if I'd run the study long enough for every single person to have had an outcome, then at that point I could do the mean survival time. Okay, because that would be the average of how long everyone stayed in the study. Okay, all right. Which of the following variables is spaced with equal intervals or distances and the 0 point is not considered meaningful? It would be an interval variable, a continuous variable, ordinal, or ratio. Interval? What do you think? So is it ordinal? Why not? Because it's a continuous scale, right? Because there's equal intervals between every value, so it's definitely not ordinal. It is continuous, but we want to get more specific than that. What type is it? Ratio or interval? Remember, ratios, I can do ratios with them, so the 0 point has to matter, right? For this one, because the 0 point is not considered meaningful, if I could have negative values, that would be considered an interval variable, okay? So if I did like blood sugar, would that be an interval or ratio? Can you have negative blood sugar? No, but you should try my mom's cooking sometime, right? I'm just kidding. No. She's a very good cook, actually. But you could not have a negative sugar. So the 0 point matters. Once you have 0 blood sugar, that's you're out of blood sugar, right? So that would be considered a ratio. I could divide one person's blood sugar by another and get some inferences out of that. Okay. What about, for instance, if I was doing temperature in Fahrenheit? That ratio or interval? It's an interval. Can I have negative temperatures in Fahrenheit? 100% I can, right? How about if I was doing temperatures in Kelvin?
No.
That's a ratio because absolute zero is the thing, right? So I could do ratio values there. Now, would it be clinically useful in humans? No, I don't think many people get close to anywhere near that zero. But again, that's an example of how the differences are going to be between those. So be able to identify that sort of thing, okay? All right. Which statistical test is best used to summarize a case control study? Would I use relative risk, odds ratios, a chi-square, goodness of fit test, or survival analysis? So a case control study, what does that mean when I say case control? Typically retrospective. So I'm going to start off with people who are my cases. What do they have? They have the outcome that I'm looking for, right? So if it's lung cancer, that's my outcome, right? So those are my cases. I'm going to do it as CA. And then that's comparing them with who? It's a case control study that I'm comparing them to. Controls, right? And frequently several people to every case you have there. So control people would have no outcome, right? I'm actually looking to investing in like a little drawing tablet that I can hook up to my computer, and that should help to increase my art by at least 10%. I'm not guaranteeing anything more than that. Anywho, though, so we're looking at people who have the outcome versus those that do not have the outcome, right? The cases should be similar to the controls, right, in terms of gender, age, things like that, because you want to make sure that you're controlling for what? Confounders, right? You're looking to make sure you're comparing an 80-year-old woman versus, say, a 20-year-old man. There could be a lot of differences between them, but by comparing similar individuals together, the only difference being whether or not they have the outcome or not, lung cancer or no lung cancer in this case, then that's how they're going to be matched up, okay? So then what do? Then I look backwards in time, right? Typically this is going to be retrospective studies, and I look to see what risk factors they have present. So this one I could say, like, I'm doing a study, a case control study. I'm looking at patients with lung cancer versus those with not, and seeing what was the risk or odds. What was the odds that they were smokers? Okay, so then I can look back and see who was the smokers versus non-smokers. Okay. So you're looking backwards to see, like, did they have the risk factor or not? And so you can say that patients with lung cancer, they had 3 times the odds of those without lung cancer of being smokers. Okay? Those are the things you're looking for. So in those cases there, because we don't have a good sense of the denominator, we don't have every single lung cancer patient present here, we can say, well, what were the odds of them being smokers versus not being smokers? So if I followed, say, I was looking at 100 people with lung cancer, 75 of them were smokers and 25 weren't, then my odds ratio there would be 75 to 25. The odds of them being a smoker versus the odds of them not. That's the odds of them having that risk factor, right? And then I can compare that to the people who did not have lung cancer, the controls, and get an odds ratio. So I can say the odds of someone being a smoker and having lung cancer is 4 times higher than those people without lung cancer being smokers. Make sense so far? So odds ratios, that's what we're going to be using for case control studies, okay? When you don't have a good sense of what the denominator is. Now if I was doing, say, a forward-looking study, and I could do, say, for instance, a cohort study, how would that differ from a case control study? So cohort study is where I'm going to be starting out with the risk factor, right? So I have positive risk factor, and down here I'm going to have negative risk factor, and then I follow them forward to see what?
Outcome.
Who has the outcomes. Now in here, if I enroll 100 people in each of these studies here, I know what my denominator is. I know what the risk of them developing lung cancer. If I had smokers in one group, that was a positive risk factor, and I saw 75 of them develop lung cancer, the risk of them developing lung cancer is what? 75 over 100. 75%, okay? And that'd be a pretty bad study. I'd hate to see those kind of results, but let's just say for argument's sake, right? So in those cases there, risk is what you're looking for. If you're looking, starting with the risk factor and looking for the outcome, you're looking at risk of something happening. If you're doing a case control study, you're starting with the disease state or the outcome. You're looking backwards to see what are the odds that they had a risk factor. Generally, yeah. So again, because when you're looking forward, I can see what is the risk of something happening, right? When I'm looking retrospectively, I'm not looking for new instances. I'm just looking to see what was already there, right? Because you're looking, the past has already happened. You can't change it. I'm just looking to see were they smokers or not. Versus when I'm doing a prospective cohort study, I can look to see, like, okay, well, I have them based on the risk factors. I can see, well, who develops the outcome and who doesn't. Okay. The only thing that differs is the denominators. So with odds, the denominator is going to be the people who don't have the risk factor you're looking for. The numerator is people that do have the risk factor, and when you're looking at a risk instead, the denominator is basically all the people in that particular group. Okay, so that's kind of the difference between the two there in terms of the math. Okay, so going forward. So that one would have been odds ratio, right? Is that right, B? Yes. Very good. I remember this stuff pretty well. No. Let's say we have a researcher who's seeking a statistical test that can determine whether the means of several groups are all equal. Which of the following would be the best test for the researcher to use? Would it be an ANOVA, a 2-sample t-test, a Mann-Whitney test, or a Wilcoxon test? You think A? Why is that?
That's what it does.
You're looking at multiple groups and all comparing them together to see are there any differences amongst their means. Okay, that's what an ANOVA is. What's that stand for?
And your analysis of variance.
Yes, analysis of variance, right? Remember, it's our favorite test,
Yes.
right? Should be. Paying a lot of money to make it your favorite test. So ANOVA is going to be good when you're comparing multiple groups together. Once I find that maybe there is a difference between any of the groups, can I say specifically which ones were statistically different? No. What do I have to do after that? multiple comparisons test afterwards. And ANOVA only tells me, is there a difference somewhere amongst those groups? And then I have to do follow-up tests to find out. So for instance, if I had that previous study, we're looking at comparing the ibuprofen with all the different muscle relaxants, they could have done an ANOVA all at the same time to look to see, are there any differences amongst all those groups there? And would that ANOVA have shown anything? Probably not, because it really didn't look like there's much difference in any of the groups there, but it could have been. Maybe they'd run it a little differently or something. So they could have done an ANOVA and then comparisons afterwards, but in this case, what the only thing they wanted to do is look at placebo versus each of the different experimental groups. Okay. Okay. Two sample t-tests. We're not going to be dealing with too much. Oh, yes, ma'am.
What was the follow-up test?
Multiple comparisons test, right? So you'd end up going, you do pairwise comparisons amongst the different groups. So if you remember the video we were talking about, I think it was like the recreational versus elite runners versus like the third category, whatever. You do the ANOVA initially to see is there any difference between the groups there, and what you found was the recreational and elite ones, there was really no difference between those groups, but then there was a big difference between like the elite and the non-runners, right? So you do a follow-up pairwise comparisons after that. In those cases there, you have to account for the family-wise error rate. Remember, what does that family-wise error rate mean? All of the comparisons I make added up have to meet that 0.05. That in order, and that is to limit making what kind of mistake? Type 1 error. Because again, if I keep running different comparisons, I'm going to find something just by chance alone. Okay. Now, is it an ANOVA? Is that a parametric or non-parametric test? Parametric, right? And what does that mean? I'm working under the assumption that I'm working with a normally distributed set of data, the Gaussian distribution. Okay. What about the t-test? It's going to be Gaussian, right? Assuming a normal distribution. What if I'm using non-normally distributed data, but I subject it to a parametric test? You're more likely to make a type 1 error. It's easier to find a difference using a parametric test because the assumptions are a little more lax in terms of the actual, what you're assuming is the data in terms of variance. But if I were to say use a normally distributed set of data and subject it to non-parametric tests, more like, yeah, because it's more stringent, it's more difficult to find differences, you're more likely to make type 2 errors there. So that's why you always want to make sure that if they test for normality, they use the right kind of test there. Okay. Everyone with me? Now in the article we were looking at, did they say anything about checking for normality? They didn't. So, but again, did they find any differences? No, so ultimately it didn't really matter so much, right? Anyway, but the Mann-Whitney test and the Wilcoxon, those are both going to be non-parametric tests that you will see used a little bit later on here. Okay. Let's say we're performing a case control study in which you're looking at patients who contracted measles versus controls that did not, and then determining whether or not they're vaccinated. Which of the following statements would be true? This is an example of a prospective study. Vaccination status is a nominal variable. This is an example of a randomized controlled trial, or a relative risk would be the best way to report the efficacy of the vaccine at preventing measles. What do you think? So let's look at the first one. This is an example of a prospective study. Is this the case? No, because what am I looking at first? Comparing if they have measles or no measles, and then what? I'm looking to see, do they have the risk factor of being vaccinated or not? And so in that case, if I want to compare the two, would I do a risk ratio or an odds ratio? Odds ratio, right? So because you're looking backwards in time to see if they have the risk factor, you're looking for the odds. So people who had measles had 3 times the odds of not being vaccinated than people who did not contract measles, right? So vaccination status is a nominal variable. Is that true? So vaccination status is defined as yes or no. It makes it nominal. It also makes it what? Binary dichotomous variable, right? There's only 2 answers to it. Either yes, you're vaccinated, or no, you're not. Okay. So that would be the correct answer here. This is an example of a randomized controlled trial. How would I perform a randomized controlled trial like this? Looking at vaccination and measles. I would take 100 people and give them the vaccination, 100 people with no vaccination, and I look to see who gets measles, right? That would be an example of a randomized controlled trial. They're randomized to the groups, and then I control one with no vaccination, one with vac. How would you blind a study like that? Yeah, you have to inject everyone. One would just get injected with saline or something like that, right? Okay. Relative risk would be the best way. We said no because, again, when you're doing a case control study, you don't know what your full denominator is, and so that's why you use odds instead. With the risk factors, if I was looking at absolute risk differences or risk ratios, I could do that if I had a prospective sort of study. Okay, like cohort study, I could look at just people who had been vaccinated, those who had not, and then look forward to see who develops measles. That would not be randomized at that point. I'm just kind of using more of a kind of a convenient sort of sample there. But then you could use a risk ratio. Okay. Let's say we're performing a study, and I miss number this one, but we're performing you actually you went to a fugue state because you're so enamored with EpiBio that you missed like the past 10 questions. So, but I'm recording, so we had to catch up on it. I'm just kidding. So I'm performing a study in which you're randomizing 3 independent groups of patients. So I have an N of 120 to receive either 30, 60, or 120 milligrams of oral pseudoephedrine, and I measure the mean changes in their blood pressure. Which of the following would be true? Performing multiple unpaired t-tests would lead to an increased chance of a type 1 error. The null hypothesis would be that the 120 milligram dose of pseudoephedrine would increase blood pressure the most. Means of measuring blood pressure does not need to be included in your results, meaning how you actually acquire the blood pressure. And then a two-way ANOVA is needed to determine if you can reject the null hypothesis. So let's kind of go step by step. So performing multiple unpaired t-tests would increase the chance of a type 1 error? 100%, yes it will, right? So what would be the best way to compare these 3 groups together initially? I do an ANOVA to find out is there any differences amongst the groups, and then I can do multiple tests afterwards, right? And then again, all the pairwise comparisons, so comparing 30 to 60, 30 to 120, and 60 to 120, I would have to have a family-wise error rate of 0.05 to make sure that I'm correcting for that, to make sure I don't find that type 1 error, okay? And that is something they should be deciding a priori. A priori just means what? Before you get started, right? The null hypothesis would be that 120 milligram dose of pseudoephedrine would increase blood pressure the most. What's my null?
They're all the same.
Yeah, it'd be the same. The dose has no effect on differences in blood pressure there. Just giving pseudoephedrine would cause a change in blood pressure, and that would be it. Okay. The means of measuring blood pressure does not need to be included. What does this matter?
Yes, it does.
Yeah, because if you had different measurements, right? Someone was using, then whether they're standing or sitting, and they're using their leg or using their arms or getting central venous pressure or whatever the case may be, that needs to be explicitly stated there, how they actually got their measurements, okay? And then a two-way ANOVA is needed to determine if you can reject the null hypothesis. That is not true. You just need a one-way ANOVA. A two-way does what? That would be in the case if I wanted to look at 2 independent variables. So say, for instance, I was looking at the dose of pseudoephedrine I was giving, and then I also looked at, say, gender or race, or if they had previous hypertension or something. When you have 2 independent variables there, that's when you use the two-way ANOVA. Okay. All right. Which of the following is a non-parametric test used to evaluate non-paired data? So being able to recognize the test and see if this is appropriate for the type of data you're looking at. So is it Wilcoxon, a Spearman's rank correlation, linear regression, or Mann-Whitney U-test? I think. It's non-paired data, it's non-parametric. So could I use a t-test here? No, why not? T-test is a parametric test. I can't do that, right? If I wanted to use, say, for instance, paired data, but it was parametric, what could I use? You do paired t-test, sure. Okay, so let's look at the non-parametric equivalence though. So what would I be looking at here? So the Spearman's rank correlation, what did that help us determine? That's where if we had the data and we were looking to see what the best fit line is, say we had a bunch of different variables, we were looking to see what the best fit line was between them, that would be that rank correlation, okay? What about a linear regression? What is that? That's where I use data like this and I try to predict the values of y from x. That's where you're trying to generate those models, right? So that we can apply it out to other populations, potentially other samples. So it wouldn't be these two. Now the question is a Wilcoxon sign rank test or a Mann-Whitney U-test. Go back and review those charts to see which ones kind of data they're going to be good for. I'll tell you the Mann-Whitney U-test is going to be for unpaired. Is that right in the notation section? It is, right? It should be. So again, you have to go back and review some of the stuff sometimes and get to really oddball different tests here. But the Mann-Whitney used for unpaired data. So for instance, if the samples have no relation to one another, otherwise I can use that Wilcoxon sign rank test. And that would assume that they have some relation to one another. Either pre-post, they're related, whatever the case may be. Okay? All right. Which of the following tests is used to assess the observed versus expected findings of a study? A paired t-test, an outlier test, normality, or chi-squared? Chi-square, right? So it's looking to see is what you're seeing in terms of frequency, is that to be expected, or is it wildly different than what you would expect just due to chance alone? So I always go back to the firemen and when they were dying sort of example. They were looking to see like, well, does Does what they're doing in terms of activities throughout the day have an influence on when they when the mortality occurs, right? So that's a good example of a chi-square test. And normality test would tell me what?
Normal distribution.
Yeah, my data is normally distributed or not. In that case, would I be looking for a high p-value or a low p-value? High p-value for normality test, because you want to say that it's very likely that the variations in your data, in your sample, would be found by chance alone. If I resampled, I'd find very similar effects there. So high p-value is good there. If I find a low p-value for a normality test, that means that my sample is very different, or very unlikely to find that kind of difference by chance alone, and so I reject that and I say it's a non-normally distributed set of data. Okay. How about an outlier test? Says, is that value that I'm looking at that's on one side or the other, is that an outlier or not, basically? Okay. And a paired t-test would be good for what? Two samples, but they're related to one another. Either they're in the same person or they're in someone who's related in terms of being siblings or something like that. Anything like that where the data is intertwined together and they could have an influence on one another as you use a paired test. Okay. Which of the following statistical analyses finds the line that best predicts y from x? I already kind of mentioned this. Non-linear or linear regression, what do you think? Linear regression is going to be the answer there, right? When you see a non-linear regression, that gets a little bit more complicated, sort of outside of our scope, but linear regression is going to be the thing we're looking for there. What are you saying?
Linear is a straight line.
Yeah, linear is just going to be that straight line. So again, if you're just trying to easily predict what y would be from x. Now, does it matter which variable's which in terms of x versus y? Yes, it does. If you're trying to predict y from x, that is where you need to do one of these regressions here. If I was just looking at a correlation, does it matter? Then it does not matter. If I'm just looking to see, do these two values correlate to one another, it doesn't matter which one's on the y versus the x axis. Once I'm trying to get into the prediction game, so for instance, if I was looking at a comparison, say serum creatinine on the x axis, and I'm trying to predict GFR, that would be very different if I put GFR on the x axis and then trying to predict what a person's serum creatinine would be, right? Again, so those are important where you put the x and the y in those cases there, okay? All right. Which is the most sophisticated method of data measurement? It'd be an ordinal variable, nominal, ratio, interval. Yeah, ratio tends to be the most sophisticated one, because now instead of with an interval variable, can I like divide one by the other? No, because that's just a ratio, right? So I can't do that with an interval variable. I can subtract them from one another, right? I can say one minus the other, and that's fine, all well and good. But if I'm trying to actually do things like risk ratio and odds ratios, I need to be using something where the 0 point actually makes a difference there. And so I'm going to use ratio variables in that point there. So those are the most sophisticated. Now, ordinal, what does that mean? There's an order to them, but the difference between point to point can be pretty variable, right? So for instance, if you're rating your professor in the semester and you say worst class ever, just an okay class, I got some sleep, or like the best class ever, there could be some variations between those values there, right? And so that would be an ordinal scale, but there's certainly still an order to it, okay? And then nominal is just what's the name, right? Okay, which of the following study designs is generally accepted as the most reliable evidence that a treatment is effective? It'd be case control, cohort, randomized controlled trial, or case series. Randomized controlled trial is always going to have the greatest level of evidence, right? Which is why, when you looked at that article previously, if you were to actually find a difference, you could say, yeah, this is a randomized double-blinded controlled trial. This is a pretty good example of pretty strong evidence. I can say that ibuprofen is better with metaxalone or something like that. They didn't find that, but that would be the greatest level of evidence here. Now, why would the case series not be very good? Because the simplest thing you have is a case report, right? You just find a patient, like, wow, that's weird, and you publish that. It's a case report. If you find a couple of patients, they're like, wow, that's weird, and a bunch of people, you can say that's a case series, right? It's a series of cases. Maybe it could be 2, could be 10, could be whatever. So can you get any kind of cause and effect sort of analysis out of that? No, because you're just describing people, basically. You're describing what happened in those patients there. What would be stronger, case control or cohort trial? Cohort is going to be stronger than a case control, because again, case control, you already had the outcomes, whether or not they had a disease state or not, whatever the outcome you're looking at, and then you're looking to see what risk factors they have, versus when you do a cohort study, you get a little bit better, because you're starting off with the actual risk factors and then looking to see what the incidence of the outcome was going forward in time, typically. So it'll be a little bit stronger, and then randomized is going to be the strongest, okay? This is important because, for instance, when I'm looking at how to treat a poisoned patient, do you think I have a bunch of randomized controlled trial on the best way to treat poisoned people? People who overdose on drugs? No, because I can't do a randomized controlled trial where I overdose a bunch of different people and see what best treatment practices are. So the level of evidence for how to best treat a poisoned patient is not going to be as good as it would be, say, for something like hypertension. Because is it ethical to do drug trials in hypertension? Of course it is, right? So again, you get much better level of evidence for certain fields of study than you would for others. So pediatrics is another really tough one. However, you go into things like cardiology, we have great studies, great levels of evidence for all of that stuff there. Make sense? Okay. Do we have good studies for like pregnant patients? Of course not, right? So again, a lot of info tends to be extrapolated back to those patients there. Which of the following tests makes no assumption about the population distribution? Parametric, non-parametric, chi-square, or normality test? Non-parametric. It's good to understand that difference there. Again, when you say that non-parametric tests, they are more likely to make type 2 errors because they're harder to achieve significance. What does that do? Does that increase the robustness of it, or does it decrease the robustness? What does that mean? It increases it, right? It means that if I were to carry out that trial again, I'd be very likely to find the same results, right? It's called robust statistics, okay? Usually non-parametric tests are going to be more robust because it's harder to achieve significance. So if you do find something, that means that, yeah, it's probably true, okay? Okay, let's say we have reading an article. So you will find some questions on the test that are like this. So again, get your reading glasses on. This one takes a little bit longer than some of the other tests you might have taken before. They do get a little wordy, okay? So anyway, so we're reading an article in which the investigators wanted to compare treatment with a new diabetic medication with placebo on fasting blood sugar. The researchers randomized 40 patients to either receive placebo or drug X. The researchers used a paired t-test and found the patients in the experimental group had a mean difference in fasting blood glucose of negative 10 milligrams per deciliter, and they had a confidence interval of negative 21 to 7. Which of the following conclusions would be correct? These results are clinically and statistically significant. Yes or no?
No.
Why not? We don't have a p-value. How can you tell? Look at the confidence interval, right? So I'm doing a mean difference. So I'm subtracting drug X group from the placebo group. And if there is no difference between those two, it would be what? 0. So if my confidence interval includes 0, then it is not significant. Does this include 0? Negative 21 to 7?
Yes.
Yes. So in that case there, this would be a non-statistically significant result finding. Is it clinically significant? Not really, right? Because it probably isn't even close to 0.05. So in those cases, I probably won't be able to take a whole lot from that. Okay. The researchers may be making a type 1 error. Yeah, we didn't achieve significance. We never rejected the null hypothesis, so you can't make a type 1 error in that case there. And it could be, though, a what? Type 2 error. That could be a possibility, right? We don't know. The researchers are using the paired t-test correctly. I think. So looking at this, the researchers randomized 40 patients to either receive placebo or drug X. The patients are completely unrelated to one another, right? They're randomized to one or the other group. You're not giving placebo to 40 people and then trying drug X to see the difference. That would be related. You're not doing it in siblings. You're not doing anything like that. This is an unpaired sort of test here, unpaired data. So in this case here, an unpaired t-test would be appropriate, okay? This hopefully would be something the peer reviewer would catch, or the biostatistician running the numbers or something like that would catch that sort of information. But it's important to understand, did they use the correct test or not? In this case, they did not. They would have used an unpaired test. Okay, and the researchers may not have had enough power to reject the null hypothesis. True, right? Because again, they found no statistical significance here, so it could be they just didn't have enough power to actually show that difference. Okay, so maybe if they had maybe double the people instead of 40, they had 80 people they enrolled, maybe they would have found something.
This might be a little specific, but is it because each group only had 20 people, and so n's not greater than 30? That you're like.
So yeah, so usually like an n of 30 is kind of considered to be like a pretty good sample size. Like, you know, it's hard to make a lot of inferences about smaller sizes than that. So as an example, like when we went to me and Dr. O and Professor Lack, we went up to Georgia for NCCPA. We did their test writing workshop, and it was just as exciting as that sounds. But we talked to, and I found that if my profession in another life would be a psychometrician. You know what they do? They just do assessments. They just do like testing assessments. I mean, these are like the biggest like stats test nerds you'd ever want to meet in your entire life. It was amazing. They're brilliant. One of the things they were saying, though, is that when you're testing the reliability of a test question that we'd be giving you, 50 of at a time, if you have a sample size less than 30, it's hard to take a lot of inferences from that, right? Because there's too much variability potentially in the data. I said, well, that's perfect because I have 63 willing volunteers every single Monday, Wednesday, Friday to test the validity of my test on. So, for instance, if I was working at a smaller PA program and they only had, say, 15 or 20 people in their group, I could not test the reliability of those test questions as well as I could in your group. Because I have a bigger sample size, and thus I can make sure that the outliers kind of cancel each other out a little bit better, and that variation goes down to some degree. Make sense? So yes, 30 is usually that kind of that classical, like, if you have more than 30, it's pretty good, right? Remember the antibiograms we talked about back in Bugs and Drugs? And the antibiogram tells you at a certain hospital how many isolates were susceptible to a given antibiotic. Usually, once we have 30, then we can consider that to be a pretty good test for them. If it's less than 30, if it's a really rare bug, we don't see that often, then we can't really take as much information about that. So 30 is that kind of number you hear a lot. Anyway. Okay, let's say we're reading an article in which the investigators wanted to compare treatment with a new, so we're doing the same medication here, same kind of results. Let's look at some different conclusions and see whether or not these are true. Fasting blood sugar is a confounding variable. What do you think? So if you had a diabetic patient and say their blood sugar coming in was 500 versus someone whose was only, say, 180, could that be a confounder? Maybe. So fasting blood glucose would be something you'd hope would be controlled for by doing what? By randomizing the patients. By hopefully you'd have these diabetic patients, they'd be randomized such that each group would have some people who are higher, some people who are a little bit lower. So you could find that fasting blood glucose could be a confounder in those cases there. So that'd be one thing to kind of consider, right? Make some sense? So they'd have to control for that. Maybe they could do in their analyses, they can control for it and say, okay, taking out the effect of fasting blood glucose, we still found these results, right? So that could be something to look at. How about whether or not the patients receive the drug as a dependent variable? What is that? As an independent variable, because who set that? The researchers do, right? What blood sugar changes they get, that's going to be what? Dependent variable, right? Because it's dependent on whether or not they were in each of these groups here. Adding a third group receiving a different dose of drug X would require use of ANOVA. That is true as well, right? So you could do that. So probably, this one could be a little bit of a. Yeah, I probably would have put two correct answers on this one. Did I forget to notate it in the bottom of the notes? I probably did. Well, you could say A and C would probably be right. C's probably more right, more technically right, but I'll consider A and C in these cases. This would be a give back if I were to only key this as C. So never say I'm not fair. You can say I'm mean, but not fair. Okay. Okay. So fasting blood sugar is an ordinal variable. Is what? Continuous, right? We said it's also one of those ratio variables because again, you can have zero blood sugar, you can't have negative blood sugar, right? Very good. Now, I just made these up today, and so I'm really proud of these ones. Let's say we have a performing experiment, which we're taking a random sampling of PA students and then randomize them into two groups. One group is exposed to radioactive waste, while the other is exposed to placebo. And we're going to follow the two groups and see who develops superpowers. Very ethical, I think. The result, we already have, you're leaving? We're already getting to the really good questions. It's fine, she'll catch up. So anyway, so the results are going to be in the table down below here. So what kind of conclusions can we take from this? Okay, so looking at this, we see the experimental group, we had 32 students, and in the control group, we had 31. I was working off some real life numbers. The percentage of people in the experimental group that developed superpowers was 23. And then you can see here that the percentages are going to be in the parentheses there. That's how frequently studies will kind of organize their charts. And then we have 5 people in the control group. So again, those lucky 5 still develop superpowers regardless of being exposed to radioactive waste, okay? So we had no superpowers in 9 and then 26. And then looking at the absolute risk of developing superpowers versus the relative risk, okay? So looking at this, let's see what kind of conclusions we can take away from this. So the study is underpowered to detect a difference. The question, did we find a statistically significant difference between these groups here? So let's look at the absolute risk. So we found 56% with 32 to 75 being the confidence interval, the 95% confidence interval here. Is that statistically significant?
Yes.
Yes, because if the difference was the same, or if the difference was 0, the two values are the same, my confidence interval would have to include what? 0 for the absolute difference, okay? Because it's one minus the other. So in this case here, this is statistically significant. With the relative risk, what I did was I took the percentages and I divided the people who developed superpowers versus those that did not, and then you get this relative risk here. So if you were exposed to radioactive waste, you were 4.5 times more likely to develop superpowers than people who were in the control group. And you see the confidence interval here went from 3.2 to 5.6. Is that also statistically significant?
Yes.
Yes, because why?
Doesn't include one.
Doesn't include 1. Okay, see the difference there? With the absolute difference, if it includes 0, then it's not significant. For the relative risk, if it includes 1, it is not significant. Keep that straight in your head because you're going to have to be able to do that on the test, okay, by interpreting a study. I won't put something so ridiculous on there, but that's something to know. So, was the study underpowered? No, because I found a difference, right? So I can at least say that I could still be making a type 1 error, but I'm definitely not making a type 2 error because I did find a statistical significance. Exposure to toxic waste increases cancer risk. Could you say that?
Yes.
Was the outcome I was looking at? No, right? So I can't say anything about cancer risk associated with this. An unpaired t-test is an appropriate test for this experiment.
Yes.
It is appropriate.
That is appropriate because are the two groups related to one another?
No.
Besides the fact they go to the same school?
No.
Exactly, they're unrelated to one another. The unpaired t-test could be utilized there. Okay, and then exposure to radioactive waste is more likely to lead to flight powers versus X-ray vision. Can I say anything about that? Not with the data currently provided, right? So this is kind of similar to when they were looking at the adverse effects in that one, the study we were looking at beforehand. They could say like, okay, well, you know, yes or no, you had adverse effects because they say that the ibuprofen placebo group caused more bleeding than the other groups. No, they just didn't do the testing to look for that, right? So if you didn't look for it, then you can't say any conclusions about it. And then similarly, we have, do we need multiple comparison corrections? Should we use multiple comparison corrections for this test here, for this experiment? No, because how many comparisons am I making? Really just one, right? Because again, while it looks like I did two different calculations there, they're using the same exact number, so I would say you probably don't need to have any kind of statistical. And again, they found very similar results there. Okay, students with superpowers already should be in an exclusion criteria.
Of course.
Yeah, so you want to start with people who already had superpowers. You want to start with people who are at baseline the same. Okay, so that would be an exclusion criteria. This would be in a retrospective study. No, because they actively either expose the people to radioactive waste or not. Not that I would ever do that to you, but I'm just saying in this case here it would be a prospective study. And then development of superpowers is an ordinal variable.
No.
What would it be?
Nominal.
Nominal, because yes or no, right? It's dichotomous. Yes or no, you either got the powers or not. Okay. Anyway, I like to have a little bit of fun here. Try to lighten up things a little bit, because this can be some pretty dry stuff otherwise.
Yeah.
My best eval I ever had for this class, they said that the subject material is like a bucket of sand, and I at least made them want to take one bite of it. Very sweet of them. Anyway, so that's all I have prepared in terms of the test review. I think you'll find pretty good similarities between this and what's actually going to be on the exam. Do you have any questions that I can answer at this time? You want to feel prepared, maybe? Yeah, so those are related, right? So when I say conservative, what does that mean? Anyone know? Not like in the political sense. I'm talking about like in the statistical sense.
Wider confidence interval? Is that what you're talking about?
It can include things like wider confidence intervals. It generally means that I'm going to be a little bit more cautious before I can say something is statistically significant. I'm going to say a little more buttoned up about it. I'm not going to just say like anything is significant. Be more conservative, meaning that it's going to be more difficult for a comparison to actually show a difference. Okay. By being more conservative, that makes it more robust. Well, it's the type of test that you're running, right? So for instance, if I had a data set that was normally distributed, I ran the normality test and it passed and said, yes, this is a normally distributed set of data. And then I subjected it to non-parametric tests, which are by nature more conservative, and then I didn't find a difference, I might have to go to the conclusion that, well, I used the wrong type of test, it was more conservative, maybe I'm underpowered to really find that difference. Whereas, yeah, type 2 error. Whereas if I were to use a parametric test, like a t-test, on that normally distributed data, maybe I would have found a difference. Those tend to be a little less conservative because you're working under more assumptions. The less assumptions you're making, the more conservative the statistics you have to use in order to prevent getting an error. So on the flip side, though, if I found data that was not to be normally distributed, it failed the normality test, and then I subjected that to parametric tests, which are less conservative, then I'm more likely to do what? To find a difference and make a type 1 error, okay? Because those are less conservative, that's less conservative of the formula, it's not going to be as conservative. Okay. What other questions can I answer for you? I'm feeling quite confident for this test.
Yes.
Again, it's a wordy one, so it's more of it's not a sprint, it's a marathon, right? So take your time, read through it. I'm not trying to trick you on anything. Like I said, you may feel that way, but I'm definitely not going to try to trick you on these. People do typically better than what they normally think. The stats normally are okay for this test. Not any worse than, say, one of my farm tests.
What's the lowest average you've gotten on this class and in farm?
Oh, actually, I don't remember what the lowest average was. Average score like on the exam itself?
Yeah,
I would say probably like the lowest is probably like an 84 or something like that. That usually will incur some give backs if I get that low. Again.
This class?
This class I don't actually know. Probably farm. Just had more farm exams I've taught. That was usually off in the beginning where I was a little bit more draconian with doling out massive amounts of pharmacy information that ultimately was going to be irrelevant for the practicing PA. But I got better from there, and I said, let's pare this down a little bit. You may not think so, but that's pared down compared to what they used to get back in the day. Any other questions? Yes. Oh, yes. Let me check this. I didn't even think about that. Let's see here. I bet there's a whole bunch of questions I just wasn't even addressing. Thereby defeating the purpose because you had to tell me to check it. So. Okay, that's good. A friend did it. Okay, so does the flat line represent? I think that was from last time, right? Okay, so do we need to go over the correlations and flat lines versus, okay, so this should be all straight there. Would a small sample size be a type 1 or type 2 error, and why? So small sample size means that the data I'm working with is typically going to be more variable. So the standard deviation will probably be larger, correct? Yeah, so small sample size means there's more variability because there's fewer people to kind of balance each other out. So a sample size of, say, 10 is going to be more variable, most likely, than a sample size of, say, 60 or 100, something like that. So when you do that, though, you tend to have a harder time finding differences. So imagine if I was comparing, say, two groups and their sample sizes were 10 apiece, an N of 10 in each sample. If I don't find any difference between those two, a lot of it could just be due to random variation. It just could be due to the fact that I do have more outliers included in that data that weren't balanced out by other people. And so because of that, I'm more likely to make what type of error? Type 2, meaning I'm less likely to find a true difference if one actually does exist, and thus I'm underpowered to find that difference by only 10 people. Whereas if I had done the experiment and I ran it again with, say, 50 or 100 people, then I have a lot more power to actually show a difference there. And then in that case, that would be power to be less likely to make a type 2 error. That makes sense. What other questions can I answer? Hopefully I answered that one satisfactorily. Anything at all? Yes, ma'am. It's a good question. So if I was using a 99% confidence interval, say, versus a 95%, what would that do to my confidence interval, the size of it, the width of it? That actually ends up increasing it, right? Because I'm saying I'm that much more sure, I have to give myself more wiggle room to be wrong, right? To make sure I can stay, say, 99% sure. Or I have to basically cover more ground in order to make sure that I'm covering everything it could be when I actually got the real population mean there. So in another way, because I'm being more conservative, I have to say, well, let me give myself more room to work with here. Versus if I said I only want to be 50% sure, I'm allowing myself to be wrong 50% of the time, the confidence interval can get very, very small. Because even if I'm wrong, whatever, I said I'm only 50% sure, you can't hold that against me. So it's a coin flip, right? Versus if I say I'm 99% sure you're not going to die from this surgery, and then you end up dying, you're probably going to be pretty mad, right? Well, maybe we'll come back and haunt the person. I don't know. So anyway, so that's what I'm saying is that the more sure you are, you have to give yourself kind of more room to work with there. So that's why the confidence intervals tend to get larger in those cases there. Okay? Any other questions? If nothing else, I would like to enjoy the weather. It'll be a reflection of your mood right now, and then I'll be here Friday after the exam. I won't be here to proctor, but I'll be here afterwards, and we'll go through and see see how well that test performs. I bet it's going to be wonderful. Right. I'll see you guys next time.